The field of minimally invasive surgery is rapidly evolving. We have seen the conversion of open surgery to laparoscopic surgery and now robotic surgery. An extension of this revolution is occurring with the use of endoscopy, allowing for unparalleled, minimally invasive surgical opportunities that reduce cost, side effects, and allow for quicker recovery of patients. A myotomy is a surgical procedure in which a muscle is cut. Myotomies can be performed laparoscopically, where surgical instruments are inserted through small holes in the torso, and muscles of the lower esophageal sphincter, or LES, are cut, followed by a fundoplication, where the top of the stomach is wrapped around the myotomy, reinforcing the LES. Myotomies are now performed endoscopically with very effective results. In this video, a muscle in the esophagus will be cut using an endoscope, restoring normal swallowing. POEM stands for Peroral Endoscopic Myotomy. Peroral means going through the mouth. Endoscopic means using the scope, and myotomy means cutting the muscle so it's going through the mouth and treating certain esophageal disorders by cutting the muscle. Esophageal achalasia is a motility or esophageal movement disorder characterized by high pressure of the lower esophageal sphincter. The lower esophageal sphincter is the muscle that controls the emptying of the esophagus into the stomach. In patients with achalasia, there are two main problems. The first is that the muscle is too tight, so it doesn't relax enough to allow for food from the esophagus to flow into the stomach. The second problem with these patients has to do with motility problems, or problems with a wave-like muscular contraction of the esophagus known as peristalsis. The esophagus has to contract to move food down into the stomach. In patients with achalasia, this movement is altered. Nerves in the lining of the esophagus regulate the movement. And rather than causing muscle contraction above and relaxation below to move food down, the nerve signals and muscle contraction becomes erratic. There are various forms of achalasia where the nerve signals and muscle contraction can become erratic in different ways. The wall of the esophagus, like all hollow organs, has a variety of layers. The layers can be accessed during the procedure to create a tunnel and a myotomy. The procedure begins as the endoscope enters the esophagus. First, a special fluid is injected to lift and form a space within the submucosal layer of the esophageal wall. After which, the doctor uses a special knife inserted through the endoscope to make an incision or cut in the lining or the mucosal layer of the esophagus. Then the knife is used to tunnel through the submucosal layer and down the wall of the esophagus. This allows the doctor to access muscle layers below. Next, the myotomy is performed. A doctor uses a knife to cut the inner muscular layer. The muscle layer is cut into the last part of the esophagus, the lower esophageal sphincter, and the upper part of the stomach. This myotomy relieves the tightness of the sphincter, allowing the normal passage of food from the esophagus into the stomach. The length of the myotomy is an additional advantage of the POEM, because prior to the procedure, diagnostic analysis tells us how much to extend the myotomy depending on each patient's subtype of achalasia. This improves the effectiveness and precision of the surgery. At the end of the procedure, the doctor uses the endoscopic clips to close the incision in the lining of the esophagus, and the endoscope is removed. Patients have to have severe symptoms, mainly swallowing problems where they're unable to swallow, and this inability to swallow is interfering with their quality of life. They're unable to put weight on, or they're losing weight. So significantly symptomatic patients are definitely eligible for the procedure. Ideally, each patient is thoroughly evaluated with imaging, motility studies, labs, and pre-POEM upper endoscopy. This, along with a thorough review of their medical history and symptoms, are considered. The patient's difficulty swallowing is measured by an Eckhart score that gives us an additional objective information. We also consider other treatment options, which include Botox injection and balloon dilation. At Parkview, I have developed a multidisciplinary program called PAGES to review each patient along with other physicians to ensure the best treatment option is performed. We understand outcomes in part by looking at quality of life questionnaires that patients fill out. along with a review of labs, post-operative tests, and a review of patients' symptoms. They assess both the pre- and post-quality of life issues. We then look at the differences. The results show that these patients have an improved quality of life, their swallowing is back to normal, and they start adding weight. We believe POEM has the advantage of replicating the traditional approach of full-thickness incision performed by a Heller myotomy, which was the standard surgical treatment for achalasia. We're replicating what they do, but since we do it endoscopically, there's no abdominal incision, no chest incision, and there is minimal stay in the hospital. So the results have been positive so far. There are pros and cons of every surgical procedure, endoscopic or laparoscopic. Every option must be considered and tailored specifically to each patient's anatomy, type of achalasia, and their symptoms. One advantage of POEM versus a Heller myotomy may be the ability to make a posterior or backside myotomy, or an anterior or front side myotomy, and also to make a longer myotomy for portions of the esophagus into the chest, which can treat specific subtypes of achalasia better. And as surgical endoscopic technology continues to grow and evolve in the future, this technique may be applied to treating other muscles that are not functioning normally, and to treating many other conditions and even removing tumors.